Vaginal delivery is preferred. For severe preeclampsia, delivery before 38 weeks gestation is also preferred. For once the decision is made, delivery induction should be carried out aggressively. Vaginal delivery avoids the addition of the stress of the surgery to the multiple aberrations of the disease. Timing is difficult and requires the obstetrician to weigh the risk and the benefits. The primary objective, however, is the safety of the mother. Complications of preeclampsia include cerebrovascular accident. The risk is low, however, it is the leading cause of death in preeclampsia. CVAs are caused by endothelial damage resulting in cerebral edema and vascular tone instability. Pulmonary edema is characterized by dyspnea, orthopnea, tachypnea, rales, and hypoxemia, and is caused by low osmotic pressure, increased intravascular hydrostatic pressure, and greater capillary permeability. Renal failure is rare but serious complication of severe preeclampsia and HELP. True incidence remains unknown. It is divided into 3 categories: prerenal, intrarenal, and postrenal. Prerenal refers to hypoperfusion, intrarenal and suggests intrinsic renal parenchymal damage, and postrenal, which implies obstructive. Majority of cases result from prerenal and intrarenal disease, and most resolve completely after delivery. Placental abruption can occur and increases the perinatal morbidity and mortality. The management of abruption depends on the extent of the abruption and associated hypotension, coagulopathies, or fetal compromise. Placental abruption is also associated with the development of DIC. HELP syndrome is a variant of severe preeclampsia characterized by rapid clinical deterioration, associated with a high risk of maternal death and increased risk of maternal morbidities, including DIC, placental abruption, pulmonary edema, renal failure, liver hemorrhage or failure, acute respiratory distress syndrome, sepsis, and stroke. It is associated with a 70% rate of preterm delivery. Prematurity related neonatal complications increase the risk of perinatal morbidity and mortality. The onset of HELP syndrome occurs antepartum in most cases, however, like up to 30% of postpartum cases. There is a lack of universally accepted diagnostic criteria for HELP syndrome, and its incidence cannot be determined accurately. Hemolysis is defined as the presence of microangiopathic hemolytic anemia, which is the hallmark of HELP syndrome. Peripheral blood smears demonstrates schistocytes, Burr cells, and echinocytes. Common histopathical findings are periportal hepatic necrosis and hemorrhage. Maternal signs and symptoms include right upper quadrant pain, or epigastric pain, nausea, vomiting, headache, hypertension, and proteinuria. Clinical presentation varies. 12 to 18% of the women may be normotensive, and proteinuria is absent in approximately 13%. Diagnosis can be especially challenging because numerous medical and surgical disorders can mimic HELP syndrome. Some differential diagnosis of HELP syndrome include acute fatty liver of pregnancy, appendicitis, cholestasis of pregnancy, diabetes insipidus, gallbladder disease, gastroenteritis, glomerulonephritis, hemolytic uremic syndrome, hepatic encephalopathy, hyperemesis gravidarum, idiopathic thrombocytopenia, kidney stones, peptic ulcer, systemic lupus, erythematous, thrombotic, thrombocytopenic purpura, and viral hepatitis. The management of HELP syndrome is highly controversial. Obstetricians have considered HELP syndrome to be an indication for immediate delivery. There is consensus regarding the need for immediate delivery when HELLP syndrome manifests beyond 34 weeks gestation, or the presence of complications such as DIC, liver failure, renal failure, placental erosion, or non-reassuring fetal status. But there is substantial disagreement regarding the management of women with stable maternal and fetal conditions at or before 34 weeks. Some people believe that administration of steroids to accelerate fetal lung maturity followed by delivery within 24 to 48 hours. And others have recommended prolongation of pregnancy until development of complications until fetal lung maturity is achieved or until 34 weeks gestation. Anesthetic management for women with preeclampsia differs little from management of a parturient without the disease. However, we must be cognizant of the disease process and be prepared for cesarean delivery at any time. The anesthetic evaluation should focus on an airway exam, maternal hemodynamic and coagulation status, and fluid balance. Airway assessment you should always anticipate a difficult airway due to diffuse airway edema. Invasive hemodynamic monitoring should be done if the patient has poorly controlled hypertension, need for repeat EBGs, use of rapid acting vasodilators, or need for continuous blood pressure monitoring during general anesthesia. Neuraxial anesthesia is recommended, and early administration is recommended to avoid general anesthesia and the possible difficult airway. An optimized timing of the placement and the setting of a declining platelet count, and also benefits include increased uteroplacental perfusion. Advantages of neuraxial anesthesia is high quality analgesia, reduction of circulating catecholamines, improved intravenous blood flow, and have a means of delivery of anesthesia for a C-section. Analgesia attenuates the hypertensive response to pain and reduces stress-related hormones and alleviates the need for general anesthesia. Disadvantages of using a combined spinal epidural: you cannot evaluate the effectiveness of the epidural until after resolution of an intrathecal analgesia. So coagulation status: there are no clear guidelines to a specific platelet count to provide neuraxial anesthesia. 75 to 80,000 is deemed adequate by some anesthesia providers. The trends in platelet count are more important than a one-time CBC. And also your whole clinical picture, not just their complete blood count and platelet count numbers. And platelet counts less than 50,000 precludes any neuraxial anesthesia. IV hydration with use of low-dose anesthetics used for epidural management. Now, hypotension is very rare. Careful attention to fluid administration is important due to the risk of pulmonary edema. In the past, when higher concentrations of local anesthetic were used, IV crystalloid hydration preceded the epidural local anesthetic administration to prevent hypotension. To treat hypotension, titrate small doses of either phenylephrine, epinephrine, and the preeclampsia can predispose these patients to have an exaggerated response to vasoactive medications. Neuraxial anesthesia is preferred for patients for cesarean section. Epidural results in more stable blood pressure, optimization of uteroplacental perfusion, and the ability to titrate local anesthetic and IV fluids. Additionally, spinal anesthesia is relatively contraindicated due to potential for marked hypotension and sympathetic blockage. Current study shows that there is no marked hypotension in preeclamptic patients, and spinal anesthesia is safe in women with preeclampsia. The choice neuraxial anesthesia for C-section does not differ greatly from that of a normal pregnant woman. The choice of local anesthetic, method of epidural, space identification, and maintenance of anesthesia are not affected by preeclampsia. 3 considerations for preeclamptic women: 1, the choice of anesthetic technique; 2, the technique for induction of general anesthesia; 3, the interaction of magnesium sulfate and non-depolarizing muscle relaxants. Careful airway exam is mandatory. Airway edema may be present, and difficult airway equipment should be immediately available. Consider having an ENT surgeon in the room using an LMA instead of repeat attempts of direct laryngoscopy. Hypertensive response to laryngoscopy can result in cerebral hemorrhage or pulmonary edema. Labetalol is a drug of choice for attenuating the hypertensive response to laryngoscopy, although isomalol, nitroglycerin, sodium nitroprusside, and remifentanil can be used. Magnesium inhibits the release of acetylcholine at the neuromuscular junction and decreases the sensitivity to the neuromuscular junction to acetylcholine and depresses the excitability of the muscle fiber membrane. It also increases the potency of non-depolarizing muscle relaxants. If they are used, they should be administered in very small doses and response should be monitored. Succinylcholine, however, is not prolonged. Magnesium depresses the smooth muscle contraction and inhibits CNS catecholamine release. There is not a risk of uterine atony, and there is not a risk of increased blood loss. Options for post-op analgesia are the same as for uncomplicated pregnancies. PCA, Norexia opioids, or continuous epidural infusions are commonly used. So consider placing an arterial line in the patients with severe hypertension. Administer labetalol, 5 to 10 milligrams, decrease the response to intubation and extubation. Consider use of labetalol for extubation. Use 50% nitric oxide with volatile anesthetic. Administer opioids after delivery. And then post-op analgesia is the same with any parturient. Patients with preeclampsia have significant risk for pulmonary edema, hypertension, stroke, airway obstruction, seizures, and thromboembolism postpartum. The revolution of preeclampsia results in marked diuresis and increase in intravascular volume and can lead to pulmonary edema. Risk for cerebrovascular accident is increased postpartum due to long duration of hypertension. Venous thromboembolism prophylaxis is recommended. In addition, severe preeclampsia, HELLP syndrome, and eclampsia can present for the first time in the postpartum period. Risk for pulmonary edema is highest in postpartum period. Resolution usually occurs within 5 days of delivery and is heralded by marked diuresis followed by mobilization of extracellular fluid and increase in intravascular volume. There is mounting evidence that women with a history of preeclampsia are at increased risk for chronic hypertension and cardiovascular disease later in life, and for an early onset of cardiovascular disease during their lives. Ischemic heart disease and stroke are the most common manifestations. Mortality in women with a history of preeclampsia is double that in women whose pregnancies were not complicated by preeclampsia. Eclampsia is defined as the new onset of seizures or unexplained coma during pregnancy or the postpartum period of women with signs and symptoms of preeclampsia and without a pre-existing neurological disorder. Any of the pathophysiological changes of preeclampsia can be present in eclampsia. The symptoms of severe preeclampsia can occur before or after the onset of seizures. The abrupt onset of seizures typically begins as facial twitching that is followed by a tonic phase persisting for 15 to 20 seconds. This progression to a generalized clonic phase is characterized by apnea, which lasts approximately 1 minute. Breathing generally resumes with a long inspiration. The patients enter a post-ictal state with a variable period of coma. The complications can include cardiopulmonary arrest and pulmonary aspiration. Mechanism of action is poorly understood. They think it is due to loss of body regulation, which leads to cerebral edema and decreased cerebral blood flow. During the seizure, provide supplemental oxygen. Ensure the patient has an adequate airway. Insert either an oral or nasal airway if necessary. Attach appropriate monitors and establish IV access if not already. Mag sulfate should be initiated if not already started. Patients with eclampsia may have increased ICP. Intake should be restricted to 75 to 100 milliliters per hour to minimize the risk of exacerbating cerebral edema. Propofol can reduce both the cerebral metabolic rate and cerebral blood flow, with consequent decreases in cerebral blood volume and intracranial pressure. Hyperventilation reduces cerebral blood flow without a reduction in cerebral metabolic rate. Hypercarbia can lower the seizure threshold. These patients usually do not have permanent neurological deficits. These are my references. Thank you.